Greetings again. It's really wonderful to see all the places where folks are joining us from. Thank you so much for making time for this webinar. We have a packed agenda and a wonderful panel of speakers. So we are going to get started, even though we have folks joining us on the webinar. Just a brief housekeeping, the webinar is being recorded and will be available on the Breakthrough Action and Research YouTube channel towards the end of the day. All folks who have registered, all the registrants will receive an email with the recording and the webinar materials after the webinar towards the end of the day. If you have questions about anything that we are discussing or presenting, please use the Q&A button at the bottom of the screen, the Zoom's at the bottom of the Zoom screen. Please put any questions for the panelists there rather than the chat. We will be monitoring the Q&A and we are aiming to have some time towards the end for our discussion. So great, with that, let me get started, and let me get started first with some introductions. We have a wonderful panel of speakers. You're hearing me. My name is Sanyukta Mathur. I'm a social and behavioral scientist with the Population Council, and I'm a public health researcher. I've been focusing primarily on examining social and gender norms on health behaviors and development outcomes, and really looking at the impact of social and behavior change programming on health and development outcomes, particularly with a focus on young people. I serve as the Senior Gender and Youth Technical Advisor for Breakthrough Research. Breakthrough Research, if you have not heard about that yet, is a USAID supported global initiative that's focused on evidence generation to strengthen SBC programming. And we have had the privilege over the last couple of years to facilitate this research and learning agenda process that we will be talking about today. I am joined today by my colleague, Krista Granger. Krista is a program coordinator for the HIV and AIDS program at the Population Council. She supported the development of the 2 research spotlights that demonstrate how specific programs utilize the RLA questions for research, monitoring, and evaluation of their programs. Next, we are joined by Kara Tereski. She leads FHI 360's SBC division, where she applies more than 20 years of experience in SBC and research to the design, implementation, and evaluation of FHI 360's SBC programs. Kara has experience in ensuring technical quality assurance, managing portfolios across multiple health, donor, and geographic areas, and in translating SBC strategies to non-health sectors. Joining us from Tanzania is Priska Rezahura. Priska is the USAID Tulonge Afya Project Director for SBC at FHI 360. She brings over 14 years of experience designing, implementing, and managing multiple donor public health, SBC, and social marketing campaigns. Her other key positions have included Technical Director at TMARC Tanzania, Coca-Cola Sapo East Africa Franchise, Regional Demand Creation Manager. And finally, we're joined by Lydia Murithi. Lydia is a project director for Beyond Bias at Pathfinder International. She's a social and behavioral scientist with over 15 years of experience as a global health researcher and program implementer. She has devoted her work to sexual and reproductive health and rights, maternal and child health, HIV and AIDS, and gender. Lydia has worked extensively in Sub-Saharan Africa, South Asia, and the United States. So we're very pleased to have this excellent panel with us today, and you'll have a chance to hear from all of us. I'm going to start off first by giving you a little bit of background and do a quick description of the research and learning agendas that we've developed through this consensus-driven process. So Krista, next slide, please. Great, thank you. So as I think many on this call know, tremendous strides have been made in the social and behavior change programming world, and SBC programs at the very basic raise awareness, reduce misinformation, and address barriers that prevent individuals, families, and communities from practicing life-saving behaviors to improve health outcomes. And despite major successes in influencing population-level behavior change, SBC knowledge gaps still remain across health and development sectors. Breakthrough research with input from USAID and implementing partners has been working to identify cross-cutting SBC knowledge gaps and implementation science research and learning agendas for select SBC themes. We built on past efforts such as the USAID Child Survival Summit and WHO's Social Behavior Community Engagement for MNCH activities. All of this work with the aim to develop documents that can guide decision-making across sectors, that can foster collective learning, that can reduce duplication of efforts, maximize the impact of research and programmatic investments. And all these things become particularly important as new and emerging approaches in SBC are being applied and require additional investigation or documentation. Next slide, please. Here I present a timeline of some of the key steps we took in the RLA process. We started towards the end of 2017 when the project had just been launched, and took a multi-pronged approach to develop the global SBC research and learning agendas on select themes and to help socialize these. Our initial steps included a desk review of SBC literature, a series of expert consultations focusing on pinpointing and prioritizing cross-cutting themes, SBC knowledge gaps, and generating questions to enhance SBC programming in complex real-world settings. And within the last year, we've developed a pair of research spotlights to showcase how current SBC efforts are answering some of the priority SBC questions, and we will be focusing on those today. Next slide, please. The two programmatic themes that emerged during the desk review, as well as a series of consultations that needed further attention, were provider behavior change and integrated social and behavior change programs. And I think many on this call probably know the definitions very well, but just to make sure we're all on the same page, let me cover just basics of both of these and what we mean by them. So provider behavior change programming, and I think as we all know, service providers play a fundamental role in health promotion, disease prevention, care, and overall well-being of our clients and communities. And effective client-provider interaction is pivotal for consistent demand and uptake of health services. And there are various approaches that are being tried in provider behavior change programming, such as training or supportive supervision, financial incentives that have been used to address factors. Some of these have been with mixed results. So to be effective, provider behavior change interventions must address some of these underlying attitudes, motivations, values, biases, and other normative factors that are driving behavior during the patient and client encounter. And so this emerged as a key area, so that the understanding was, and the discussions and from the literature, that though there have been examples that have been innovative and effective ways to influence provider behavior change, opportunities still exist to explore and expand this knowledge base. The second key area, next slide please, Krista, was around integrated SBC programming. In recent years, SBC programming has experienced a notable shift away from a vertical approach to that focused on one health or development topic to a much more integrated approach, where you're often concerned with multiple health or development issues or outcomes under the same program. Generally, integrated SBC programs aim to address these factors, the knowledge, attitude, norms pertaining to multiple health areas or development sectors, in a coordinated and intentional way that influences multiple health outcomes. Typically, this can involve strategies that are practiced by the same audience. They are looking at the similar norms and behaviors, or preceded by gateway behaviors, or looking at co-occurring health or development conditions. Some implementation models include adding on components, doing a phased rollout, or having umbrella brands or projects. And it's been hypothesized that integrated SBC programs have the potential to reduce duplication, lower costs, and avoid missed opportunities, and getting the right services and information to the right clients at the right time to achieve better success. And such integration has already started happening. What emerged from our desk review was very clear, and this very clear call from our consultations to strengthen the evidence base to support this. Next slide, please, Kristen. So as we heard in our series of technical consultations from over 300 SBC implementers, researchers, service delivery or representatives, and donors, we're really working across a range of technical areas, from MNCH to family planning to HIV, to WASH and other sectors, that there was this real need to really understand, as this one participant noted, what we really need to understand is what works for whom, at what level, for how long, and under what conditions. And this kind of conversation and discussions led to a prioritized set of questions in the research and learning agendas that are intended to be broadly applicable at global, regional, and local levels and across health sectors. So the research and learning agendas aren't specific to themes, but not to health sector. And they're meant to be adapted and refined to suit specific programmatic and geographic contexts. Some of the proposed questions can be integrated into programs' existing monitoring and evaluation systems, while other questions will require a standalone research studies or be incorporated into comparisons that account for relevant influential factors. So the RLAs, which I'm going to just show you a quick snapshot of next. Krista, if you can go to the next slide. Great, thank you. Are meant to be these kind of guiding documents. So the first document we have, and we sent this out ahead of the webinar, but I do hope you'll have a chance to look at it in detail after the webinar as well, is the research and learning agenda document focused on integrated SBC programming. In that, the group prioritized questions around 4 key areas of inquiry that are that you can see on the screen. The first is the enabling environment, really trying to understand the factors that are essential to getting integrated SBC programs to continue. And I hope our USAID Tulunga Afya team will speak a little bit on that today. The second box is a set of questions is around intervention content and programmatic model. There are, of course, questions around effectiveness of integrated SBC programs, particularly relative to vertical SBC programming. How is this added value? What is the added value? So, for example, a question in that for that area of inquiry is what are the potential unintended, both positive and negative unintended consequences at the individual, household, community, and health system levels for integrated SBC programming compared to vertical programming? And of course, cost effectiveness was a key theme. So there's a range of questions around costing and cost effectiveness of integrated SBC approaches. And I don't know if those on the call have been following the breakthrough research webinars. There's a whole series of materials around how to do some of the costing and costing primer documents that are available on the Breakthrough Action and Research website if folks are interested. Next slide, please, Krista. Great. So the second RLA document that is available for everybody to use is a research and learning agenda around advancing provider behavior change programming. Here also, the priority questions are organized around 4 areas of inquiry. The first dealing with organizational characteristics and values. So focusing on what are the norms, facility norms, profession, community norms that are most influential in shaping provider behavior in those interpersonal communication with clients. Questions around intervention strategies. How do we extend beyond training? What are the more innovative approaches around reaching providers and addressing provider behavior change? Questions around effectiveness. What are the most, for example, what are the most effective non-communication based SBC interventions that can improve provider behavior, such as changes in the waiting room or facility spaces? And then questions around measurement. There was a lot of issues around measurement. How can we best measure the quality of client-provider interactions from both client and provider perspectives? So these research and learning agendas were developed and disseminated earlier mid last year, 2019. And we've been thinking about how we take these research and learning agendas to make them more actionable. And to speak a little bit on that, on a strategy that we've employed, I'm going to ask my colleague Krista to jump in here. Krista, passing to you.
Great, thank you, Sanyukta. So to advance the RLAs, we concentrated and coordinated action needed from a range of stakeholders, including donors, researchers, SBC partners, and government and policymakers. We set out to demonstrate how priority RLA questions are being answered to improve programming, share tools and resources for other program implementation and research partners, and raise the visibility of current work in order to enable stakeholders to take action in advancing the RLAs. We decided to develop 2 research spotlights inspired by HT3's existing social and behavior change spotlights that detail the development and implementation of SBC programs in a comprehensive, visually appealing, and interactive way. We were inspired by this format for the Breakthrough Research Spotlights as a way to highlight how SBC and PBC programs answered RLA questions specifically to improve the research, monitoring, and evaluation of their programs. Developing the research spotlights was a 6-month iterative process between the program teams implementing the work, which was FHI 360 and Pathfinder International for these 2 spotlights, and USAID and the Breakthrough Research staff. We started with an extensive review of program documents like internal design strategies, survey results, progress reports, and external briefs and dissemination products. We then mapped which RLA questions each project was answering through their activities to demonstrate the approach they took in identifying the answers. Key informant interviews were a vital step in developing the research spotlights in order to better understand the contributing factors that influence decision-making and for the design and implementation of the programs. And our final steps were to synthesize the information and lay out each program's process in a web-ready format that includes links to the resources each project used along the way. So this slide provides a screenshot of the USAID Toolanga'a Research Spotlight to demonstrate how it's formatted around key approaches that addressed 4 integrated SBC RLA questions to support the development of their NOISA platform. The navigation menu on the left highlights where their key approaches of identifying enabling conditions and underlying determinants to then consolidate a strategy and evaluate their program. By clicking an item in the navigation bar, you're taken to a section of the spotlight to receive more details on how they answered the associated RLA questions shown on the right. The Beyond Bias Research Spotlight is structured in the same way, demonstrating the key approaches Beyond Bias used to address 3 provider behavior change RLA questions. The navigation menu on the left leads you to details on how they addressed these RLA questions by identifying underlying drivers, creating provider profiles, and developing design solutions that led to their final program design. So this is another screenshot of the USAID Toolanga'a Spotlight, detailing the baseline survey as one of their activities to help identify enabling conditions. For each activity, the Spotlight provides details on things like purpose, methods, and participants, as well as links to specific reports created by the program so that others can learn from and replicate these activities in their own integrated SBC program implementation. You can also see that in the Spotlight, we highlight and link to certain definitions like the enumeration areas that's here in blue, and key research methods and analytical approaches like the systematic random sampling that's highlighted to provide additional resources for anyone in need of assistance with these methods. Similar to the Toolanga'a Spotlight, we showcase the steps Beyond Bias took in addressing each RLA question and link to the reports and resources that detail their work. Here we're highlighting how qualitative design research was conducted through interviews, observations, and role-playing to investigate provider biases and behavior towards young women in order to develop solutions that improve the quality of provider counseling. With these spotlights, we highlight how research gets consolidated into their program design. So now I'd like to start off our panel discussion so that our panelists can share their direct experience developing and implementing these integrated SBC and PBC projects utilizing the RLAs. Kara and Priska have joined us to share about the USAID Chilonga Afya Naweza platform, and Lydia will share about the Beyond Bias project. So Priska and Kara, could you give us a brief overview of your project and share how the approach in this project was different than what's been done before? And then we'll hear from Lydia for an overview of the Beyond Bias project and their own unique approach.
Thank you, Krista. USAID Chilonga Afya is an integrated social behavior change project which primarily supports 5 thematic health areas. As USAID's flagship project in Tanzania, we also provide technical support to emerging health issues. The project's goal is to catalyze opportunities for Tanzanians to improve their health status by transforming social and cultural norms and promoting the adoption of healthier behaviors. In working towards this goal, the project addresses 3 key intermediate result areas at the individual, community, and systems level. With regards to the project's coverage and implementation mandate, working with our government counterparts, Chilonga Afya provides social behavior change technical assistance at the national level and has an implementation mandate in 19 regions where the government of Tanzania and USG implementing partners are working to strengthen the provision of integrated health services. Within these 19 regions, we also conduct direct implementation of community-level SBC activities through 2 local NGOs across 29 districts, also known as municipality councils in other countries. Where needed, we also provide strategic social behavior change technical assistance and support beyond the project's SBC integration mandate. Next slide, please, Krista. In terms of the project's integrated social behavior change theoretical framework and theory of change, added, which Kara will talk to later, this approach informed the design and development of our government-led and coordinated Naweza platform, which is the subject of today's research learning agenda. Next slide, please. Briefly, the Naweza platform, which targets adults 18 years and above, engages our target audience during 2 important life stages in their lives, pregnancy and childbirth, as well as caregiving for an under 5-year-old child. The platform uses a range of integrated SBCC approaches across multiple channels to meaningfully engage with the target audiences and to influence key determinants of the behaviors we seek to change and which were prioritized with the government of Tanzania and other stakeholders. That's it on the project overview. I would now like to invite Kara to highlight how our approaches are different from past interventions in Tanzania and globally, and more importantly, to highlight how these have been applied towards the development and design of the Naweza added platform. Kara, over to you.
Thank you so much, Priska, for the good project overview. As Priska described, Chilonga Afya is one of USAID's largest integrated social and behavior change projects. It is complex in that it seeks to change behaviors and social conditions that underlie them across many health areas, and also in coordination with many different types of stakeholders, while also strengthening capacity and systems for social and behavior change. While prior to this project, there were some efforts to deliver integrated SBC campaigns in Tanzania, Chilonga Afya was really the first of its kind in country in implementing such a large-scale integrated SBC program. I think the project has innovated in many ways that have advanced the practice of integrated SBC, both within Tanzania as well as within the global arena. And for me, this innovation has stemmed from how the project has rooted itself in community, while at the same time been grounded in science. This is in both how we understand the context in which we are working and use data to deliver evidence-based SBC programming, but also in how we segment, understand, and really embrace our beneficiaries, not only in the design of our activities, but also their delivery. So I can share a few brief examples. The first is how the project has designed and applied a range of different research and human-centered design methods that informed our SBC strategy, and we'll go into much more detail about that later in the webinar. The second was our approach to audience segmentation and our framework for delivering an integrated SBC program. Many similar programs use a life stage framework for integration, often coupled with an umbrella brand to link together different life stage specific SBC campaigns or packages. And we've also employed a life stage approach, but we're a little bit different in that we recognize the need in Tanzania to delve more deeply and to distinguish more deeply between SBC strategies targeted and their unique needs, as well as to adults or those who are soon to become or who are already parents, in addition to those facing chronic illnesses such as HIV. This resulted for Tulangayafia in the development of 2 distinctly branded and robust SBC platforms, Sitatareki, or Unshakable in English for youth, Naweza, I Can for adults, as well as a long-running campaign, Furaha Yangu, or My Happiness in English, which addresses the unique needs related to HIV and TB. Each of these the campaigns and platforms delivers targeted activities across a range of mutually reinforcing channels. The third innovation has been our approach and really our philosophy to co-design and what we call co-delivery. Under the project, beneficiary participation is a critical component in not only how we design our program, but in how we also deliver it. And our content is often generated by beneficiaries themselves through sharing their real life stories, or it emerges directly through participatory dialogue processes. And then lastly, the project has employed a very strong adaptive management approach and routinely uses an array of data. This includes routine M&E and service level data, as well as the ongoing application of insights, which are generated from the project's feedback loops as part of their activities. So if you're interested in these approaches, I would encourage you to read more in the Tulangayafia Integrated SBC case study, and we're happy to answer questions as well. Over to you, Krista.
Great. Thank you so much, Priska and Kara. Now we're going to hear from Lydia a little bit about the Beyond Bias project.
Thank you, Krista. So the Beyond Bias project is a Gates-funded project implemented by Pathfinder International in collaboration with YLabs, Kimber Collective, and Berry. And the project employs a comprehensive multidisciplinary approach integrating AYSRH expertise and evidence with the human-centered design, behavior economics, and segmentation analysis. The goal of the project is to design and test innovative scalable solutions to address provider bias. And the project is currently active in Burkina Faso, Tanzania, and Pakistan. Now, as you all know, I mean, provider bias is really not a new thing at all. It's actually existed for decades. But what is unique about the project is that we set out to disrupt the status quo on how the field has responded to this persistent barrier to care. So far, what the field has done primarily is training of providers and supervision of providers, and that has not been as effective. And so our multidisciplinary approach and our multidisciplinary team brings together a diverse perspectives and ways of thinking to tackle this sticky challenge. Next slide, please. So as illustrated on this diagram, the project employs a phased approach. We have 3 sequential phases, the research phase, intervention design phase, and the implementation phase. So we started with the research phase to generate evidence and insights to inform intervention design, which was our second phase that applied the human-centered design methodologies. So the intervention design was guided by was guided by the human-centered design methodologies. And we are currently in the pilot stage of the implementation phase. So that's the bright green bubble. So current stage of the implementation phase, where we'll be implementing the behavior change model that resulted from the design process for a period of 1 year, and conducting a randomized control trial to assess its effectiveness. Now, for clarity on timelines, I would like to clarify here that just recently, actually as recent as September, that's last month, we restarted the pilot due to COVID-19 interruption that forced a 5 months pause on the project. So we're just starting again and afresh, and barely 2 months into it. So implementation will go through September of 2021, and with data collection and analysis running through the end of 2021. Thank you.
So now I'll pass it back over to Sanyukta to lead our panel discussion.
Great, thank you very much. I think we have given everybody on the webinar nice teasers of these fantastic projects. And I'm sure you are all who are listening and participating and wondering where to get more information. And so hopefully you'll stay on for the discussion. We're going to talk about these things, but then afterwards, please do check out the research spotlights or case studies, as Kara called them, where you can see more details about each of these projects as well as the resources that they have shared with us. So let me ask a few more questions. And this one, Lydia, maybe I'll ask you to answer first. In each of these research spotlights, we focused on priority research and learning agenda questions that your project was answering. In some of the cases, your projects were using multiple methodologies or approaches to answer these questions. Could you share an example of how using multiple methods, research approaches, strengthen your learnings for program development or refinement?
Absolutely, thanks, Sanyukta. So our solution development process was evidence-driven, iterative and collaborative across partners and disciplines. We actually were extremely deliberate about ensuring that the various methodologies spoke to each other, so to say. We asked ourselves critical questions. For instance, how do the research findings inform solution design? What more can we learn from the HCD process to further deepen our understanding of how bias manifests in different contexts and why? Also, how might we integrate some principles of, behavioral economics to make our solutions more desirable to providers? So just as a way of example, just number one, through the HCD process, we gained insights that complemented other research findings on drivers of bias. So for instance, one insight revealed that providers have one foot in the community and another one in the clinic or in the facilities, which means that they are often conflicted and struggle to reconcile professional norms from their own personal values. So this revelation helped us understand why training providers has not been effective in addressing bias so far. And in response, we explored skillful ways to guide providers through a process of self-reflection to help them, own their own biases and commit to a peer-supported journey of overcoming them. Another example on how we integrated these methodologies into our solution development is on how we've applied the segmentation analysis into the design. So our intervention model is made up of 3 pillars. I hope you've seen them before, but I'll just very quickly here note them, and we have them again on our documents that are highlighted on this spotlight and also on our website. But the pillars include the summit, which is an impactful story-driven event, Connect, which is a peer support forum for providers, and Rewards, which is a performance-based non-monetary incentive. So the pillars are standard across the 3 countries, so that in Tanzania, Burkina, and Pakistan, we still have the Summit, Connect, and Rewards, but the pillars are customized in each country to the contextual needs and the uniquenesses of these countries based on segments. And so that's how we applied the segments. So a great metaphor that we use, or we like to use, that helps distill this information is that of a pizza. So food, anyone? So a pizza, thinking about a pizza, so the pillars are the pizza crust, which is made of the same ingredients, and then the segments are the pizza toppings, which are, which vary depending on the contextual peculiarities or needs in each particular country. So we find this design that it makes the model easy to adopt and scale in different contexts. And finally, another example is how we, integrated some principles and ideas that came from, or that come from behavior economics, which is the importance of incentives in behavior change. So we built in value for providers within the solution, within the intervention, in such that in every pillar, we do have a value built in for a provider, where a provider can feel this is what is in for me. So for example, in the rewards, we have increased social and professional status for providers. We have those opportunities for them. And then in Connect, we have created a space to share, connect, and reflect with peers. And finally, with Summit, we've created a sense, created for them a sense of support through, community. I mean, through community, their own community respected community persons. So even though non-monetary, we're using non-monetary incentives here for scalability and sustainability reasons, providers can see, what is in there for them, and hopefully this increases their motivation to change their behavior.
Thank you, Lydia. I think that is some really rich information you've shared about Beyond Bias. Let me turn to the USAID Tulonge Afya team, if they could share an example or two of how using some of the different approaches and methodologies sort of guided their program development or refinement. Kara or Priska, would you like to chime in?
Sure, thanks, Sanyukta. In response to this question, I'll begin and then I'll hand it off to my colleague, Priska.
Great.
So for those of you that have read the Tulonge Afya RLA, you'll see that we used a wide range of research methods to better understand and co-design solutions with our beneficiaries, as well as for our continuous program improvement and strengthening. These included workshops in the beginning with stakeholders to prioritize behaviors that Nweza subsequently addressed, a comprehensive literature review, stakeholder interviews and mapping, insights gathering activities where we use projective techniques to identify and understand emotional drivers for our behaviors. And then once the project began implementation, our formative really didn't stop. We then continued to gather insights, including use of the Passages social norms exploration tool, which helped us to deepen our understanding of family planning and reproductive health factors. As I mentioned, we also routinely use M&E and programmatic data to strengthen our program, and Priska's going to talk a little bit further about that. What I think is an important takeaway is how these varied sources of data came together to inform the project's SBC strategy. So for example, we conducted a household level baseline survey, which you saw on the slide earlier, which provided us with information related to knowledge, attitudes, and practices. From this data, we also then conducted doer and non-doer analyses, which helped us to look at the demographic and psychographic or attitudinal differences between those who reported performing the project's priority behaviors versus those who didn't. So we use this data to determine what factors might be related to our beneficiaries' ability to carry out the behaviors, as well as where there was room for our project to improve upon. So a really brief example of this is those who used a modern contraceptive method, for example, they reported that they were more likely than non-doers to engage in dialogue with others around methods and to perceive that their partner was supportive of their use of methods. So based on this, these are factors that we have targeted within our program and that we seek to address. We then layered this with the qualitative data, the insights that we gathered from our audiences, as well as the data from the social norms exploration tool to deepen our understanding of these factors. And then that subsequently helped inform the platform's content, prompts that we use within our small group dialogue sessions, as well as our media programming. So this is just one brief example, and I'll ask Priska if you have some additional thoughts to share here.
Thank you, Kara. An example that I would like to share of this application is really how during the design and rollout of our integrated Nweza platform, it was very important to ensure that nested within our programming was a robust monitoring, evaluation, and research system, as well as learning agenda. So adding to what Kara mentioned, our project also uses multiple methods to gather and triangulate routine project data and beneficiary feedback insights to really help develop and refine our programming. Some of this data and trends are gathered via a quarterly omnibus survey, an annual sentinel survey, as well as through a qualitative midterm evaluation that was led by Breakthrough Research. These approaches have allowed us to routinely assess progress against key indicators which I'll talk to later as I give specific examples. So this is all part of our adaptive management approach, where we use the routine analysis and use of data really to help us identify successful approaches that can be scaled up and gaps that need to be addressed as part of a comprehensive iterative process of reviewing and refining our social behavior change strategy and theory of change. So for example, through the Omnibus survey, which is a quantitative survey that is administered on a quarterly basis with a nationally representative sample of the project's target audience, we're able to gather and analyze the segregated data on reach, recall, and exposure to the project's intervention, as well as messages, and also helps us to track our progress against the key behaviors and determinants that the project seeks to address. So in terms of a determinant example here, for early antenatal clinic attendance visits, the two key determinants that are being addressed under the NAWESA platform includes service access, self-efficacy perception, and male partner support. What was notable regarding these determinants when the data was desegregated regionally was that there were key geographies and target audience segments where changes were lagging behind versus what we had targeted, whilst in other geographies were doing really well. So this insight helped us to inform key media broadcasting, message refinement, programmatic adjustment, as well as intensification decisions. And this was all done through a series of core refinement sessions that were implemented with our target audiences across the priority focus of regions of focus. In addition to this data analysis has also allowed us to more sharply address regional and context-specific service uptake barriers, leveraging the CNET insights that Kara talked to, as well as key cross-cutting gender norms, roles, and relations. That's it from my end. So Sanyukta, back to you. Thank you.
Thank you, Priska and Kara. And Lydia, all three of you have really spoken with such great detail and specificity about some of the ways that the research has been used to help develop and refine programs. And I think part of our objective in collaborating on these research spotlights, these case studies, was really to share some of these tangible research resources with the broader SBC community so that they can see the kind of research efforts that are going in, the methodologies, the sequencing of them, the timing of them, and how they're sort of feeding into programming and program refinement. I know we're running short on time, and I do want to leave time for at least a few audience questions. And maybe I can put this question to the panel. And Tulonge Afia team, maybe you first to get us started. In your opinion, how would this design, this product support, our research spotlights, in your opinion, how do you think this could support design and implementation being undertaken by other SBC partners and projects? Kara and Priska, if you guys want to start off, and if you can please keep it brief so that we can get to a couple of questions, that would be great. Thank you.
Thanks, Anita. We'll keep it brief. So from my perspective, I think this research learning agenda or case study really illustrates a few important design and implementation considerations that can help other social behavior change programmers. The first is that the design of an integrated SBC program requires adherence to a systematic design process. For us, this included a distinct design and stakeholder engagement, as well as buy-in phase, as well as continuous programming improvement and refinements during implementation. The second, while we did not speak to this element of the design, of our design in today's webinar, our partnership with USAID, the government, and key stakeholders to advance the NAWESA platform has been significant and is highlighted further in the case study. As we discussed today, I would also like to emphasize that partnership from our perspective also includes engagement of our project beneficiaries throughout. Kara, do you have other thoughts?
Thanks, Priska. I completely agree. And I also think from a programming perspective that the case study is really helpful for implementers in understanding the time and investment needed to design and deliver high quality integrated SBC programs. And I think I saw a question on that in the Q&A as well. I think these factors are not always fully understood by donors or implementers and are often underestimated. I also think the case study demonstrates that we need to have a broad toolbox of research and design approaches to pull from based on context and need, and that not one size fits all. So many of our tools have been shared as part of this case study, and we also plan to disseminate our community level toolkits that we're using, as well as other resources later this year. But ultimately, though, what we used in Tanzania may not be appropriate for another context, or it may require adaptation to translate it to another setting. That said, however, I think that what this case study does exemplify is the importance of ensuring a science or evidence-based approach, and one that is deeply grounded in the needs of the community it serves. And where possible, in our opinion, this would be an approach where solutions are co-designed and advanced directly by program beneficiaries themselves. And then these would be our top recommendations in applying the lessons learned to date from Tulonge-Afya to the design of other programs. And I think it's also this very combination of approaches that have helped us to deliver a quality program that really does apply a range of interventions. And we've been, just quickly, we've been seeing that the findings that we've been seeing upward ticks in self-reported behaviors and determinants, as well as related to social norms. And then Priska, I know, did you have anything just to quickly close?
Yeah, just quickly in closing, I just wanted to say that, Tulonge-Afya and Inaweza, we just have slightly more than another year of implementation. And during this time, we hope to continue to learn from our beneficiaries, to use data to strengthen our programming, and to share the approaches that are working, as well as those that aren't, more broadly within Tanzania and globally. We're really excited to continue to be able to deliver against the project's mandate and goal of improving the health status of my fellow Tanzanians through social behavior change program, which for me is an honor that Tulonge-Afya and FHI feel truly privileged to have been provided. So thank you so much. Sanyukta, over to you.
Thank you. I think you both raised some really important points about timing and adaptation of resources that I think are important to keep in mind. And in part, our ideas and the reasons we sought out to collaborate with Beyond Bias and the USAID Tulonge-Afya project were because these projects were taking sort of different and innovative approaches. So Lydia, let me just ask you the final question, and then I will open up for audience questions. Is what are your thoughts and opinions on how this research spotlight, this case study, can support our SBC community writ large? How can we support the design and implementation being undertaken by other SBC partners?
Right. I'll keep it brief because I know we ran out of time. But well, first, I would like to note that ours is a work in progress. It's important to note that we are still in the initial stages of the pilot phase. So this is a proof of concept project. That said, though, from the research and intervention design phases, we've generated rich evidence and key insights on provider bias, including drivers of bias, how bias manifests in FP services, service delivery in 3 geographies, provided research tools and evaluation frameworks, as well as laid out behavior change, a behavior change model that we are currently piloting. So even as we wait for findings from the RCT on the effectiveness of the model, the resources we've shared and that are highlighted in the spotlight or the case study could definitely inform ongoing programs. Now, one other point that I would like to make is that our work has also unearthed areas that need further research and exploration. So for instance, on measurement, to add to your repertoire, Sanyukta, on measurement, more research is certainly, more work is certainly needed in figuring out more cost-effective and scalable ways of gathering credible and reliable feedback from youth clients on their contraceptive counseling sessions. Our experience has been that a combination of low literacy, young people's heightened need for confidentiality and privacy, along with stigma around young unmarried women use of FP, all kind of make up for a complicated recipe that makes it difficult to collect feedback from this subgroup of clients in a cost-effective way. And finally, closing and related to that point is a question of technology use among youth. There is always an assumption that young youth equals technology, digital generation, happy-go-lucky, but we've learned that young women's technology use technology use behavior patterns, which often include, sharing of devices like phones, and in some cases, mistrust of technology can quickly complicate the viability of a digital intervention. So there is a need for more investigation and documentation of these patterns, even as digital health becomes more and more of a necessity given the times we are living in. Thank you very much.
Thank you, Lydia. That is fantastic to I think, several points you made, and particularly the point around recognizing that both of these case studies are really sort of living documents, and particularly the Beyond Bias one, because what we are hoping and aiming to do in the next year is to continue collaboration and see if we can add to the spotlight, to share some of the evaluation results, perhaps even develop the research spotlights. And the spotlights are supposed to be these living products and serve as a resource. We're getting a lot of page views, so I hope that that means that colleagues on the call and others are tapping into them. I see a lot of questions in the chat about specific questions about USAID Tulongea and the Beyond Bias project, and I urge you to go to these spotlights because our partners have really provided a lot of details and reports and documentation about how this process worked, the approaches they used, the kinds of results they found in applying each of the approaches that they have highlighted just briefly today. And I do want to open it up now for just a couple of minutes for a question. I realize that time is short, and we will probably not get to detailed questions on each of the projects. But to highlight that what our collaboration thus far has been underpinned by this sort of need to enhance the evidence base for integrated SBC and PVC programming. The RLAs give us this framework, a set of priority questions that can then be adapted and refined. And these research spotlights present sort of a concerted and coordinated collaboration with USAID Tulongea Afya project and with the Beyond Bias project to try to collect and understand how current projects taking particularly innovative approaches are trying to address and answer some of these questions in the program implementing process. So with that, Krista, is there one or two sort of burning question, something that's been asked often by our colleagues who are joining us on the webinar that you want to put out there?
Sure. We've had a couple questions about challenges, so maybe we could have the panelists talk about their main challenges in the design and implementation of either the integrated SBC or the PVC program.
Yeah, and I think that's a great question to start with. And Kara, you started talking about that a little bit in terms of timing and understanding the timing it takes for some of this innovation. And Lydia, you mentioned that as well, of having to, well, in this case, dealing with COVID and restarting piloting. But I'd love to hear from the panelists on some of the timing issues, or sorry, challenges. And I won't call anybody out, whoever feels like jumping in.
Well, I can get started. So one of the strengths, like I highlighted, a strength of our project is our, various disciplines and perspectives that comes into the work to think this through. But I would like to be honest and say that it's not like we're holding hands singing Kumbaya every day. These interactions can be tough sometimes because, we have people coming from various, different mindsets. And so we embrace the tensions that do exist in those moments because when we have those tensions, that is, an indication that there's something to explore there, there's something to pull, and there's something to create together. But it is, it can be quite time consuming, that we need to be, I think, projects that take on this kind of integration, interdisciplinary or multidisciplinary approach needs to be aware of the time for coordination. The other thing that I think we've learned and we're learning as we go, and HCD is a newer because it's becoming more common tool within the global health. Budgeting for HCD is one thing that we are learning, and we're learning that you can't quite budget for it at the beginning, as the structures of budgeting will have to change a little bit, especially if you use HCD in an intensive way like we did.
That's really interesting. And Lydia, you always have really fantastic phrases. So I love the embrace the tensions. So Kara, Priska, anything to add on challenges and embracing the tensions?
Sure, I'll start and then I'll turn it over to Priska. I mean, I think from our end, we were designed to work hand in glove with service delivery partners. And so one of those tensions has been the need to immediately provide support in terms of demand generation and creating an enabling environment. So I think when Tulanga Afia started, we felt the need to hit the ground running, but we knew that to design a well thought out strategic SBC program, that we really needed the time to do the evidence, to understand the evidence, and to have that design and stakeholder buy-in period. So we implemented programs, SBC activities that had been implemented in the past. We adapted them and got them on air, so we were able to, and in the community, so that we were able to immediately support our service delivery partners, while we gave ourselves that time to better understand our audiences and the needs related to the integrated programming design. And then I think there was a question on this, and this also speaks to it. We also phased our program. So we started with a package for under NWESA that was related to pregnancy related behaviors. And then a year later rolled out the caregiving package. And so this enabled us to space the program a little bit more in a more feasible way. Priska, do you want to add to that?
Well, for me, I just wanted to add that the biggest challenge when we were rolling out our integrated platform in Tanzania was, we were supporting 5 thematic areas and getting all these thematic areas to really believe that, all their different priorities and behavior change needs can be addressed under one platform. It took time. So, really selling the concept of integrated social behavior change and getting our different clients and the different, thematic health programs at the Ministry of Health to buy in, that took time. But it got easier once, the platform was rolled out and they saw how we were actually implementing and delivering the interventions and how those were responding to their specific unique needs in an integrated way. It was easier. So this is something that where this approach has yet to be implemented in other countries, they probably need to consider and maybe to even think about drawing from other countries, including our case studies, to showcase examples. Thank you.
Those, again, really fantastic insights. Krista, I don't know if there's another burning question. I know we have 2 minutes before we end the call. I do see a lot of questions specific to USAID, Tulanga Afia project and Beyond Bias. And so maybe, sorry, let me pause, Krista. Is there any other burning question that you think is coming up that is sort of common from the comments?
Well, one of the questions, maybe the panelists can give a brief answer, was what are the tools and resources that you would point to for use for either SBC or PBC programming?
Great, thank you. USAID Tulanga Afia team, would you guys attempt that one first?
Sure. For us, I mean, I think there are a variety of high impact practice briefs that we consulted. We did a lit review in country to understand what had worked in country. And so we tried to be as specific to the context in which we were operating. We also consulted a range of, many of our community level activities are very participatory and use games and other interactive activities. So we look to those types of programs to adapt and to learn from their results. And then I think, in terms of, some of that is detailed in the case study as well. And then we've also provided all of the resources that we've used along the way in terms of the design process. And we'll be putting out the materials and the program kind of toolkits over the next year as well too, if that's helpful for people. Priska, do you want to add to that from Tanzania?
No, I think we're good.
Sorry, Priska.
I noticed the time.
We are now
sorry.
actually at 10, and so Lydia, I will let you answer because I don't want to cut you off. And then
that's actually okay because we have everything listed on the spotlight, so I won't hold people back.
I apologize for that, and I
okay.
really do wish we had longer time for some of these great questions that were coming in. Krista, if you could go to the slide where we have, for more information, the one after this and the one. Yeah, so I just want to point people again to places where you may be able to get answers for some of the project-specific questions, both the Pathfinder and the FHI 360 website. Certainly start with the research spotlights where you can get information on integrated SBC and provider behavior change. And there's a number of upcoming events that may be of interest. I saw questions coming in around provider behavior change solutions. So next Monday, actually, Breakthrough Action is hosting a webinar on PBC and FP, and you may be interested in that. Lydia had mentioned the issue around provider behavior change measurement, and my colleague Martha Silva will be presenting some interesting work that they've started doing on looking at around measurement of provider behavior change. There is a springboard discussion happening, and I have not participated in those, but I hear that they're very interactive and a lot of interesting stuff, especially around new ways of doing measurement and monitoring on social listening to inform SBC programs. And finally, there is a webinar on October 29th on an integrated SBC project in Nigeria. This one looking at insights to improve malaria, family planning, and MCH outcomes. So there's a lot of resources available, and we look forward to continuing to engage with you. Thank you so much for giving us your time. A huge thank you to our panelists. Thank you for giving us your time. And I think, should I leave with embrace the tensions and let's figure out how to collaborate and generate the evidence that we need for enhancing SBC. Thank you.
Let's do it. Thank you so much, Sanyukta.
Thanks, everyone.
Thank you all.
And everyone.
Thank you, everyone.